Hi, this is Dr. Crawford, second part of the Harvard Medical School meeting update on breast cancer in July 2023. Part 2 is on radiation therapy. Now keep in mind that the purpose of this summary is to inform and educate the public. No medical advice is offered, and please consult your physician if you have any questions about breast cancer. We're going to be talking about post-surgical radiation, which is the latest research on radiation therapy for patients who have received surgery for breast tumor removal. This is a very important current area of interest because there's a lot of data that have accumulated from clinical trials, giving us insight into the best clinical course of treatment for different types of breast cancer. The image here is from the American Oncology Institute, which is an excellent resource to find out more about many different types of cancer. So the meeting stressed that an important area of current clinical research is to decide which patients may benefit most from post-surgical radiation. Several important clinical trial studies were discussed with respect to how they may inform current treatment decisions on an individual patient basis. Now, we all know that breast cancer is a multifaceted disorder, many different types of disease. It's very important to understand the best therapeutic approach for each type of cancer, and that is the current goal in clinical medicine. The first study that was discussed was the British Columbia study carried out between 1979 and 1986. Although some of the treatment methods are outdated, however, the duration of this study is very important because it gives us long-term follow-up statistics, and the study was fairly well conceived of and carried out. The study involved 318 premenopausal women, younger women, who had node-positive breast cancer, meaning the tumor had spread to the lymph nodes. There were two treatment arms. One group received radiation, the other did not, although both groups received chemotherapy. It was a long-term study that followed patients for 25 years. And at the 20-year follow-up, chemotherapy and radiation combined were associated with a statistically significant improvement in all areas analyzed over simply using chemotherapy by itself as a single agent. So this was a very important, informative study. What it showed was that isolated local regional recurrence, or LRR, which is recurrence of the tumor in the breast area, decreased from 26 to 10% in patients who received both chemo and radiation. Overall survival increased from 37 to 47% in patients that received both treatments as opposed to only chemotherapy. On this basis, the study authors concluded that patients with high-risk breast cancer, premenopausal, node-positive disease, at that time treated with modified radical mastectomy, there are newer surgical approaches available now involving simpler lumpectomy, using post-surgery, a combined treatment of radiation and adjuvant chemotherapy leads to better survival outcomes than chemotherapy alone. Here is a graph of some of the data that were published. And this shows all patients in the study. There's approximately 10% survival difference in those that received both treatments versus those that received only chemotherapy. In patients who had nodes 1 to 3, meaning 1 to 3 nodes contained cancer cells, here we see a better survival statistic, regardless of the treatment modality, but certainly when you combine the radiation with chemo, we're seeing at least a 10% increase in survival long-term at 20 years. So this is, again, very important positive statistic. As we get to patients who had a greater number of nodes, the long-term survival picture is not quite as good. However, we do see an even greater effect of combining the chemotherapy with radiation, up to about 40% versus less than 20% after 20 years. So the first study then gave us some very good data on premenopausal women who had node-positive disease at the time of diagnosis. The second study discussed was the Danish 82 B and C studies that were carried out between 1982 and 1990. Again, the area of focus was radiation therapy versus no radiation therapy. Those were the two study arms, study groups. 82B contained a large number of patients, 1,375 postmenopausal women. So here we're dealing with a different age demographic who were less than 70 years of age, who received adjuvant tamoxifen for only 1 year. The second group, 82C, these were 1,708 premenopausal women, younger group, who received adjuvant chemotherapy and radiation. Their characteristics were high-risk tumor greater than 5 centimeters, and they were node positive or showed invasion of the skin or fascia at the time of diagnosis. These individuals, again, this was earlier time point when mastectomy was more common. These patients received total mastectomy and lymph node dissection, and an average of about 7 lymph nodes were removed per patient. So these would be premenopausal women, high risk in the second group. The study concluded that post-mastectomy radiotherapy decreases the recurrence of disease in the breast and improves overall survival in patients, in those patients who are node positive, meaning they have lymph node involvement in the cancer and they are high risk. Now, this was an older study limited by the fact that it involved outdated systemic therapy and the axillary dissections were done differently. So again, there are some caveats in interpreting this, but overall, it certainly was a study of significance. Now, this is a revisiting of the Danish study. This is a publication from March 2022, post-mastectomy radiotherapy in high-risk breast cancer patients given adjuvant systemic therapy. So again, here we're dealing with whether or not radiotherapy had a positive effect. This is a 30-year long-term report, and they did some additional research on the patients that could not be done at the time the study was initiated. They found that post-mastectomy radiotherapy resulted in a 4-fold reduction of the 30-year recurrence at the site of the breast, from 37% to 9%. So that was a very compelling statistic. This in turn resulted in a reduced overall mortality or death rate with 5% difference after 30 years. The mortality rate was 5% higher, not quite as dramatic as the local regional recurrence rate, but nevertheless statistically significant for those patients who received radiation. They had a 5% difference in mortality, improved mortality. Similarly, post-mastectomy radiotherapy reduced the risk of developing distant metastases. So that was a very important statistic as well. And the failure due to any recurrence, so in terms, it affected all types of recurrence, had a beneficial effect, not happening because of the RT, and death from breast cancer. So the RT radiotherapy was shown to be very important in all groups. The radiation, which itself could induce side effects, was found not to increase the risk for initiating a breast cancer in the contralateral breast, the other breast that was initially not affected. Today, the breast cancer radiotherapy is even more targeted, so that is certainly a very important consideration as well. So after 30 years of follow-up, 60% of the patients had developed a recurrence, including 731 or 24% with locoregional failure, recurrence of the breast tumor, and 2,699, 88% had died. This is at 30 years. So 62% of those from breast cancer and 25% from other causes. Now remember, this was an older study and some of the treatment methods were not as effective as they are today. However, the study continues to be useful because, as I mentioned, the Danish study was re-examined. So what happened was they were able to now study the tumors using more modern methods to examine the importance of estrogen receptor, progesterone receptor, human epidermal growth factor, and other subtypes of breast cancer that are now decipherable, that were not easily distinguished 30 years ago. So this was a large study originally that randomly assigned patients to receive or not receive post-mastectomy radiation. And the analysis that was conducted 30 years later took those same patients, 1,000 of them, and they did a further analysis. So they looked at the patients that about approximately half who had received radiation, half who did not, and these were from the original Danish Breast Cancer Cooperative Group, using studying patients post-menopausal below the age of 70 and premenopausal with advanced breast cancer. So what they did was they took tumor specimens now and they were able to stain them to determine what their clinical status was in terms of whether they had hormone positive receptors or not. So this is done by a method called tissue microarray. They were stained for the estrogen receptor, the progesterone receptor, and HER2 status. And the median follow-up time for the patients alive was 17 years. The comparison between receptor status and disease outcome, called an endpoint, were the recurrence of disease as an isolated first event, distant metastases, and overall survival. And they divided the groups into 4 groups based on their hormonal receptors that were stained when the tumors were analyzed. So these are the 4 groups. Receptor positive are those patients who were ER positive, estrogen receptor positive, and or progesterone receptor positive. Receptor negative as those that are estrogen and progesterone receptor negative. And here we have the subgroups are receptor positive, which would be estrogen, progesterone, and HER2 negative, which is a different receptor. Receptor positive and HER2 positive, meaning you have both sets of receptors. Receptor negative and HER2 negative, which is generally called TNB or triple negative, having no receptors. And receptor negative, HER2 positive. So here are the data shown graphically. Group A is ER positive, estrogen receptor positive. In overall survival after 15 years, there is no RT is the yellow line. They show a significant increase in overall survival. In panel B, progesterone receptor positive, no RT has a lower overall survival. Panel C, HER2 negative, here for local regional recurrence, this would be recurrence of the breast tumor in ER-positive patients who received radiotherapy. Recurrence was much lower. Recurrence was much lower in patients who were progesterone positive. Recurrence was much lower in patients who were HER2 negative. Recurrence was lower also in patients who were ER negative. Okay, so where you have no RT, the recurrence is higher. Here in E, where you have progesterone negative and no RT, recurrence is higher. And the same is true in F, where you're HER2 positive, recurrence is higher where there's no RT. So even though the effect on overall survival is not seen except in the hormone receptor positive group, local regional recurrence is delayed in every group, although the degree of delay is significantly better maintained in the group that is hormone receptor positive, where you do see some coming up in the numbers with groups D, E, and F. However, there is still an important contribution of the radiation to local regional recurrence, even though not on overall survival. Okay, and again, this is simply a recapitulation of that data. Okay, so we're going to move on to another study. This is the Early Breast Cancer Trialists Collaborative Group called the Oxford Review. This is an international group of scientists that gets together periodically to assess hundreds of clinical trials worldwide and compare them and try to make sense of all the extensive research going on. And a recent meeting of this group has shown, their report stated that the effects of radiotherapy for early stage breast cancer, indicating that the proportional effects of radiotherapy after breast conserving surgery are substantial for both patients who are node negative as well as node positive. Okay, so after breast conserving surgery, they found that overall there is a positive effect of radiotherapy, regardless of whether or not the tumor has spread to the lymph nodes. And that there were substantial reductions in recurrence of the disease and improvements in survival with post-surgical radiotherapy after breast conserving surgery. So that was the Early Breast Cancer Trialists Collaborative Group. That was their original review data on this subject. The overview analyzed a large number of patients and clinical trials, and their data indicate that radiotherapy reduces recurrence of breast cancer and all-cause mortality in both groups of node positive and negative, and they're not substantially reduced by side effects. So that, again, is important because radiation does have side effects, but these did not seem to impact the positive effects of the treatment. And this was a durable response over 15 years follow-up. This involved, again, an early analysis. Treatment methods were different, and so we have to use caution in interpreting, although there is some value to going back to these older studies, hence they were presented at this Harvard Medical School conference. This was an analysis of a large group of patients, 8,135 between 1960 to 1986, 22 clinical trials. involving the use of post-surgical radiotherapy versus no radiotherapy, followed by, in those cases, modified radical mastectomy. Again, the treatment methods have changed. Lumpectomy being much more common today. 10-year follow-up in this study. And the patients were node positive. So the tumors had spread at the time of surgery to their lymph nodes. Among women who had 1 to 3 positive lymph nodes for tumor cells, the risk of local regional recurrence, in other words, the return of the tumor, was decreased when radiotherapy was added to the chemotherapy regimen. Again, substantiating some of the earlier studies that I focused on today. This is the reference if you would like to read the paper. It says it's from The Lancet. Effective radiotherapy after mastectomy and axillary surgery on 10-year recurrence and 20-year breast cancer mortality. And this is a meta-analysis comparing a number of studies. And here are our graphs. So starting over here, we have any recurrence. So here we're looking at any kind of recurrence of disease. This would be the percent over here, and this would be time. And this would be, over about a 10-year span. Well, 15 years. 10 to 15, but most of it's cut off before 15, so about 10 years was their cutoff for most of this. At any rate, over here we have, this is surgery by itself. This is a first recurrence rate after 10 years, 31%. Surgery and RT, again, 15%, so basically cut in half. And this is at 5 years. So very compelling statistic. And this is with women who had no lymph nodes, zero, node zero disease. You see quite a significant difference. Over here we have breast cancer death. Here we have just the surgery and RT, and we don't see such a great difference. So although we have recurrence, or some women who did well and did not recur, when you compared all the overall, the death rates were in 10 years similar. Now this is women with node positive disease. This is over here, first recurrence. And here we have the group that received surgery, and we're very, very high here. We're up to, over 60%. And at 5 years, we're at 53%. Whereas those that received RT, we see 30%. And at 5 years and 42%. So significantly less recurrence, and also an impact on the death rate. So we have 42 versus 51. So higher death rate from those who only received the surgery versus radiation. And again, this is an older study, so the chemo was not used in the same way that it is now. So again, these statistics are not going to hold for today. They're just giving us a sense of the impact of radiation in and of itself. And that can be informative, although certainly is not going to be decisive in terms of these types of decisions. So it was concluded that patients with node N0 did not benefit because there wasn't an overall survival benefit. But 1 to 3 node positive patients, greater than 4 node positives, they did demonstrate both a local regional reduction as well as a mortality benefit when radiotherapy was used after surgery. Now, the final piece of this that I want to mention is from a paper, actually a commentary that was published in September 2022 by the executive editor of Harvard Women's Health Watch. And I want to stress that there's quite a bit of research going on about whether or not women with early stage breast cancer can skip radiation after lumpectomy. So this is an entirely different group. And I just wanted to quote from this article. It summarizes very important work that's ongoing. And in future podcasts, I'm going to certainly go into this topic in greater detail. But given the fact that this is on breast cancer, we want to, and its latest developments, I would be remiss if I didn't mention this important group of women. So here what we're really talking about is breast conserving surgery, where the lump, the tumor lesion, is removed. And should we take node 0 early stage breast cancer, small tumors, node 0, should these patients receive radiation therapy? And this is a very important area that's being studied now. And we don't have any decisive answers, but I think it's important to know what's going on. So this commentary talks about research that's been going on since the early 2000s, which are helping cancer experts develop guidelines defining which women with early stage breast cancer can safely omit radiation after lumpectomy. Currently, this option is offered to women of 65 or older who have small tumors. So the size of the tumor is small, they're non-aggressive, and there's no lymph node spread. And that's called a T1, stage 1, node 0, grade 1 to 2 tumor. Small, early, non-spread tumor. The tumor must be estrogen receptor positive. All right, so it's only for women that fall into the T1, N0 who are ER positive, meaning that the hormone estrogen helps fuel their growth. Also, at the time of surgery, you have to examine the margins and make sure there's no local spread and all the tumor has been taken out. And women who decide to omit radiation, who fall into this category, instead receive only the endocrine therapy. So all women who are ER positive will receive endocrine therapy, which we're going to talk about in a separate podcast. But this group would receive that only. And that usually is a standard of 5 years. And this will prevent the cancer cells from utilizing the hormone and prevent any recurrence. And that is the goal of using this, although we do see occasionally recurrence. But this group is a very, very good group medically in terms of full recovery. And this has been a standard of care for a long time in women 65 or older. But now the question has moved to whether or not we can omit radiation for a larger group of patients. So what if we can go down below age 65, if we can find the right group of patients who, as a whole, have demonstrated that it's not needed? Okay, so this is really a very, very important question that was talked about at the meeting, and that's why I'm summarizing some of the current thinking here. So what does this new evidence suggest? So the new evidence suggests that younger women with tumor features similar to women who are older, 65 or older, which is at their T0, N0, T1, small size tumor, no spread, no lymph nodes, would they there is some evidence that some of these younger women may be able to forego radiation without raising their odds of recurrence. So they would just take the endocrine therapy for 5 years. And this was a study now moving down 10 years to women 55 and older. 500 women with early stage breast cancers, similar to established criteria. Okay. It also allowed women to enroll if the margin breast tissue was very thin, all right? So you have very small, thin margins. Use an extra test on tumor cells removed to confirm that they're slow growing. So all indications that this is an early stage, non-aggressive cancer. Over an average follow-up of 5 years, the study revealed that the rate of breast cancer recurrence in the same breast was 2.3% in women who skipped radiation after lumpectomy, but also took their endocrine blockers. So this, again, is only the ER-positive women that were involved in this study. So only 2.3% breast cancer recurrence in patients who skipped the radiation who fell into this particular group. So the commentary concludes that these are promising results, but daunting obstacles remain. The study's results are still considered preliminary. Further well-vetted research is needed to confirm its results. An additional barrier that makes it difficult to translate these results to clinical practice is the reliability of the test to determine that cancers are slow growing. So in other words, we have to make a uniform standard of assessment that is used, a broad spectrum, among clinicians in order to standardize this particular treatment option. So again, this is the encouraging part is that this is going to be used to analyze and review other studies omitting radiation to identify additional patients with invasive breast cancer that's very early stage for whom radiation can be omitted. And we're going to have to wait for the final story on that one, but just to make you aware, this is the kind of work that's going on in research on radiation, and I'll keep you posted as new developments occur. Thank you for listening, and you can contact me at www.cancerupdates.info, or you can send me an email at drsa.crawford@cancerupdates.info. Stay tuned. Part 3 on endocrine therapy will be coming soon.